Okay, so the topic that I'm going to deliver today is on implant rehabilitation, surgical and restorative treatment planning from a prosthodontics point of view. I've actually chosen myself because Dr. Fidaus gave me the chance to choose whatever topic you want to talk about. So this is the topic that I want to talk about. And one of the reasons why I have chosen this topic is so I can actually express and demonstrate some of the photographs that I have been taken, that I have been undertaken while I was training at Eastman Dental Institute. Okay, so the topic that I'm going to deliver today is on implant rehabilitation, surgical and restorative treatment planning from a prosthodontics point of view. Okay? Right, so here is some of the outlines. Basically, before we start on any implant cases or even any of the restorative cases or any of the dental treatment, we have to go through the history examination, special investigations and diagnosis. And with that steps, then you move on to do what we call a stabilization phase. So I will go through with you what stabilization phase means, and then there will be another stage called jaw registration and articulated study cast, and diagnostic phase, a bit of a treatment planning, and then some talk about surgical phase and restorative phase, and then finally with the maintenance phase. So this is the outline that I have that I'd like to go through with you. Okay, so why I am standing here? So I just want to actually just give a brief overview of what prosthodontic specialty is, and show you, so that will justify my presence here in the workshop, which is a specialty that relates to the diagnosis, treatment planning, rehabilitation, and maintenance of the oral function, comfort, appearance, and health of patients with clinical conditions associated with missing teeth and deficient teeth, including maxillofacial tissues using biocompatible substitutes by means of fixed removable implants and maxillofacial prostheses. And this has been taken from the ADA, American Dental Association. So now, coming back to the actual title that I have chosen, implant rehabilitation. So what is it actually? So this is an example of a full mouth rehabilitation in a complex crowns and bridge work, and this is a patient who has had basically a generalized tooth wear necessitating a full mouth rehabilitation. So as you can see, this is a full mouth reconstruction done by one of my colleagues at Eastman Prosthodontics. So what he has done was providing upper right 3 to 3 with composite build-up, and 4 and 6, and the other side 4 and 6 with a PFM crowns. Okay, and then looking at the bottom arch, I think the patient also had a generalized tooth wear, reducing the vertical dimension. So the full mouth rehabilitation takes place involving an increase in vertical dimension constructed in a reorganized occlusal manner. So as you can see, you can have a couple of gold crowns at the back teeth, PFMs, and lower composite build-up. Okay, so if we want to convert that into implant rehabilitation, we would view using the same concept. We are managing the patient's occlusion. We are actually rehabilitating patients' missing teeth. We are actually providing a new or conform the patient's occlusal surfaces, which I will begin talking a bit more later. And this is my case, which is slightly more conservative as compared to my colleagues, which have a lot of conventional preps. As we are nowadays moving more towards conservative and more aesthetics. This also patient who has had a generalized tooth wear of upper and lower arch, and the patient has had a history of acid reflux for many years, and also a heavy intake of diet cokes. And therefore, what we have provided is a full mouth reconstruction with upper 3 to 3 palatal gold backings with a composite build-up, 4-5 on the upper arch with direct composite build-up. The lower is a 2 to 2 composite PFMs on the lower canines, composite build-up on the 4-5s, and gold onlays on the 6s. Okay, I think one of my colleagues here, we have been trained together in Eastman, Dr. Nazar, she has also carried out similar full mouth reconstruction, but in the children. So I think prosthodontics is more working in the adults. Okay, so this is another example of another full mask reconstructions involving a fixed and removable prosthesis in order to manage patient's occlusion, replacing the missing teeth. So basically, postodontics, we are looking into rehabilitation of the patient's missing teeth and reconstructing the occlusal surfaces. So that includes either with fixed prosthesis, removable prosthesis, or implants. Okay, now I have looked at the glossary of postodontic terms in 2005. The definition of implant rehabilitation is restoration of the form and function of the masticatory apparatus to as near as possible via dental implants, either with single, partial, or full arch. As you can see, when we try to build up the occlusal surfaces, we try as much as possible to maintain all the occlusal anatomy, the fossa, marginal ridges, and the fissure patterns. And in order to also making sure that the patients feel comfortable and the occlusal is in harmonious with the rest of the dentition. Okay, this is another case, full mask occlusal rehabilitation with combined crowns and bridge work, and also dental implants. As you can see, there are some implants on the upper left region that to replace the missing 5, 4, 5, and 6. But at the same time, the patient needs some kind of a form of rehabilitation or reconstruction treatment. And usually these patients, they are the tooth wear cases. They are patients who have a severe or generalized tooth wear, patients with missing teeth, for example, hypodontia, amylogenesis imperfecta, dentinogenesis, and patients with failed dentition. These are all the patients that require reconstruction. Okay. Now, the aim of the implant treatment is to provide replacement of the missing teeth and occlusal rehabilitation by means of dental implants, either in a conformative or reorganized occlusal approach. So, for example, a patient who requires an occlusal filling, yeah. So you may not want to build up the amalgam high, so that the patient won't have a high bite. So you are actually conforming to the patient's occlusion, so that the patient will feel comfortable. And that is what we call conformative. As you have seen in the photograph I have shown previously in the previous slides, they are the reorganized nature. They are very complex cases that involve 2 to 3 years treatment. While I was in ISMO, we spent 2 to 3 years restoring all these cases. But in the private setting, it can be shortened down because of better facilities or close monitoring of the patient. So the duration can be shortened down to at least a year or a year and a half. But the reason why we want to restore with the implant is to replace missing teeth, to restore the occlusion, so that the ideal occlusion will contribute to the greater success of the restoration. So if we actually pay more attention to the occlusion, we are actually trying to maintain the success and the survival of our restorations, including the dental implants. So that is my introduction, why I want to talk about from implant rehabilitation point of view. Okay, now looking at the patient assessment, as you're all aware, we are all clinicians. We have seen a lot of patients. We need to consider one of the most important things is the expectation, patient expectation. We have to evaluate the patient's needs and demands. If the patient have a high expectation, then the clinical skills involved will be high as well. So we have to be clinically prepared in order to restore, for example, a single missing tooth who demands a very highly aesthetic case. And also the financial cost and time. If the patient doesn't have, if the patient doesn't have too much money at their disposal, then you may want to consider a lot of other factors in your treatment planning. Okay, so you also have to find and to outline the reasons for tooth loss. Patients who have caries as a result of their tooth loss, periodontal disease, you have to in fact see whether is the existing disease is still remain, or whether you have to eliminate the disease, do the stabilization phase, control, eliminate all the caries that the patient have. And basically there's no point planning, restoring or placing a complex implant within bridge work, whereas there is a big caries on the upper right central incisor. That's, for example, that's what I meant. So you have to treat in a more holistic approach or more holistic manner. So medical history, you have to make sure that there are no medical problems that is contraindications to surgical. One of the most important things is, for example, bleeding disorder, patients undergoing radiotherapy to the head and neck that will actually impart or prevent the healing potentials. So if you put an implant, there could be, osteoradionecrosis or the avascularity of the blood supply of the bone. So you have to be careful with some of the medical conditions. And the other things that has been quoted mostly on the papers in periodontology and some of the, some in the dental articles is about the smoking. If the patient's on heavy smoking and also uncontrolled diabetes, you have to be careful. If the patient is on controlled diabetes, on medications or diet, having diabetes, then that is something that you can consider. Okay, examinations. So this is to identify any dental problems or any dental disease and to establish the ideal oral health status back to normal. So if the patient has a deep caries lesion, so you want to address that under the stabilization phase. If the patient has a chronic gingival, chronic periodontitis, you want to address that. You want to liaise with periodontitis, manage all these gum disease until the patient has reached stabilized maintenance phase. Then you want to consider the implants. Okay, the other thing is you also have to evaluate the space for a dental implant. Whether is it adequate to have a dental implant, what size of the implant, what length, and how much bone quantity and quality. The nature, thickness of condition of soft tissues, for example, if the patient has thick keratinized gingival tissue, so you have a better control of the gingival tissues. If the soft tissue is of a thin keratinized type, then you have more challenging because the tissue may more likely to relapse or have some kind of a gingival recession. So you may not want to have a dental implant at the same time showing a bit of a neck at the crown of the tooth. So these are something that we as a postodontists consider in our treatment planning. Then whether the case is restored in a conformative or reorganized occlusal approach is something that you have to ask regularly. You will see a lot of patients requesting multiple implants or multiple crown and bridge work, whether you restore in a conformative or occlusal, reorganized occlusal approach. The complete dentures patients, for example, they are a type of reorganized occlusal approach that we are mostly feel that I haven't done or haven't have the idea what reorganized occlusal approach is. The complete denture patients, they are an example of a simple reorganized patient. Okay, now I'm just going through a bit more of some slide, and then I can show you some of the photograph. But we must not forget about the investigation. For example, the use of OPG, periapical radiograph, CBCT scans, Canora, which is a spiral tomogram, CBCT scans. And don't forget the study models, which have been articulated on the articulator, and do all the appropriate measures such as full pericharting and determine the prognosis of disease. Okay? So this is an example of a radiographic stent. As you have taken the cone beam CT scan, you use a radiographic stent which have made of a combination with barium sulfate and cold cure acrylic resin. So you try to actually fit in the patient's mouth and take it with the cone beam CT scan. So it will show as a radio opaque in the radiograph. Then you can plan where you want to put your implant. So basically, from postodontics point of view, it's all about planning, and then from the planning you deliver to the final restorations. So it's a lot of planning, and then comes to the surgical and restoration phase. So this is an example of radiographic stent of the upper and lower arch. This is an example of a cone beam CT scan of the. Basically, we are considering the mandibles at this stage. You can see more mandible than the maxilla. So you can see the radio opacities on as determined by the radiographic stent. So you know exactly where you want to put the implants, whether or not there is a bone concavities on the labial aspect of it, whether you want to avoid that or you want to do some kind of bone augmentation, how long is the implant, what is the width of the implant. It's all determined from your diagnostic wax-up. So if you have a diagnostic wax-up done, you show your patients, you try to do a mock-up on the patients, try in, then the patients will be able to see what the result, the final result is like, then you try to deliver according to what you plan. Okay, so this is a bit of an architecture work, or engineering bits and pieces. So you plan things and then you deliver the final towards the end, according to what you have planned. So the diagnostic work, the most important thing is an articulated study cast in a major complex cases. Then you take a jaw registration, you do some diagnostic work, and then you start considering what kind of occlusion scheme you want to provide. Are you going to conform? So if you're going to conform, does the patient have a good function, a canine guidance, or guidance on the posterior teeth? do you want to either retain that or maintain that, or are you going to change that? So when you change that, that includes a more complex, reorganized manner where you give patients, for example, a mutually protected occlusion, if you have heard of it, which is a canine guidance, where the posterior teeth are in contact in ICP, and then the canine helps to actually eliminate any lateral excursive contacts, which will be damaging to implants and restorations. And you may want to also consider radiographic stent from your diagnostic work, and then you are able to evaluate the bone quality and quantity, and whether or not the grafting is required or sinus floor elevation is required. Okay? So now this is an example of articulated study cast, which is a semi-adjustable Dina articulator. So we mount that in ICP and we start doing our diagnostic wax-up. So the right side is an example of the diagnostic wax-up from this articulated study cast, and the left side is actually the more of the full mouth rehabilitation diagnostic wax-up. Okay, so this is an example. So this is an example of a diagnostic wax-up to replace a single missing tooth, and this is this patient is a 24-year-old black lady who demand a very highly aesthetic case. So it's a very challenging case. We have to make a very nice diagnostic mock-up, try it in the patient's mouth, and then make it as part of your treatment plan and consent. Okay, so this is a treatment option. So you have following all the diagnostic, special investigation and diagnosis, you will go through treatment options. What are you going to restore? Maybe the patient is not possible to have an implant because of the the bone size. The patient may not want to go through the surgery, complex surgery, don't have the money to pay for it. Then you can consider, for example, a resin retain, fixed resin retain bridge work on the top picture, or the patient may consider a combined fixed crowns and removable partial cover cone, for example, on the lower picture photograph. So you may either do nothing, you may want to provide with removable dentures, conventional adhesive bridges, or fixed implants, either with single toes or implant within bridge work, or you may want to provide a removable type of implant prosthesis such as overdenture. This is an example of upper complete acrylic overdenture and lower partial acrylic denture. So this is an example of a type of treatment option that you may want to consider in your case if the implant treatment is not an option. So in terms of the implant selections, which implant system you want to choose? So we have a lot of implant systems in the market. We have a winter implant, we have a Neos, we have Astatec, Nobel Biocare, strongly on the bones, whether it's maxilla or mandibles. It's all depending on the case selection. And in second stage, you would open up the access to the implant head and change with the healing apartment so you can actually contour the soft tissue. The position and angulation of implant will be determined by the use of, for example, surgical stent or a guided computer generated surgical stent. In the simple cases, you may not want to use surgical stent. You can just visualize from the clinical situation. But in the complex cases, you may want to pay the lab to make a surgical stent from your diagnostic workshop. So this is an example of an atraumatic extractions in the patient, and then we plan to put the implants as early as possible, which is in less than a month's time. So we consider an early type of placement of implant because the patient have baby teeth retained, or deciduous teeth I should say. So, okay, this is an example of a sinus floor elevation which I have carried together with the consultant in Eastman Prosthodontics. Is using the lateral window techniques involving this case. Okay, so some patients with a complex cases, you may want to consider a sinus floor elevation and then put some grafting and allow for healing before considering implant. Or maybe this sinus lift can be joined up together with the implant placement. So it's something that you may want to consider when you're planning. So this is an example of a picture of a bone grafting in restoring upper left one with some bone grafting and chin bone graft. So this is a chin bone graft taken from the bone taken from the chin and transferred to the upper left one due to the concavities on the labial surface, the labial aspect of the bone, and then we allowed for healing. Actually, in this case, we allow up to 6 months before we introduce to go and put the implants in. Okay, so this is the real position of the flap after putting the graft, and this is a review 8 months Okay, and then we make the surgical stand from our diagnostic wax up, and then we make a surgical flap, and then put the implant according to the diagnostic wax up. Okay, so you can see the diagnostic, the surgical stand has actually determined the placement of the implants according to your diagnostic planning. So this is the surgical stand in place, and you use the drilling stages, all the protocols, and then you try to enlarge the sites using stage drilling protocols. And then you put the implant in, and then you put the healing abutment. So we consider one stage protocol in this case. Okay. And this is the implant system 3i, Biomed 3i from the US. Okay, and then we put the healing abutment, as you can see on one of the lower left photograph. Okay. And then we also do some augmentation with BIOS and also the osseous coagulum. Is that right? Osseous coagulum? Yeah? Yeah. So the patient's bone traps and everything, so we just collect that and then we apply on the labial aspect of the defect due to the small amount of resorption from the bone graft, and then we allow it for healing. Okay, so this is a healing. We adjust the denture so that it doesn't impinge on the soft tissue, and this is after a couple of weeks review. Okay, so now we talk about the restorative phase. There are a lot of things that we need to consider in the restorative phase, and the top right picture is actually the picture of angulated abutments from NEOS, and that is the screw, all the stack of screws available from the Biomark Nobel Biocare system. You have to consider what type of provisional, or basically the loading that we want to. Are we going to give the tooth right away? Is that going to be early or delayed? Is it going to be as soon as a couple of weeks or as delayed as a couple of months? And then we have to consider impression stage, jaw registration, the selection of the abutments, and how we're going to provisionalize the tooth. And we have to consider the occlusal consideration, soft tissue profile development, and whether is it going to be a screw or cement retain. And we have to make sure when we deliver the final restoration there is a passive fit, because the passive fit will not introduce too much stress and forces into the implant that will can actually damage or break the implant. This is an impression of a full arch implant. This is one of my membership exam cases that I have used to present. So this is an example of a jaw registration for a full arch. We were using the pattern resin, or basically equivalent to dual-layer resin, and we take the jaw registration in a reorganized occlusal approach. So we must not forget that we are working in a team. So we need the laboratory support as well. So one of the most important aspects related to the laboratory support is the production of working casts, the selection of abutments and components, and the design of the superstructure, the waxing up to a full contour, casting up the metal superstructure, whether you want to resort to making acrylic or porcelain work, or you want to use a CAD-CAM. I remember when I was in Eastman, we were working really hard to finish our cases. We stay in the lab. I think Dr. Nazar remember what all the postdoc guys were doing in Eastman. We stay late. We come back home 8, 9 o'clock, even sometimes 12 o'clock, so just to finish our lab work. So it's a lot of work. And this is an example of the cases that I have done with a CAM structure Biomed 3i on a full arch implants. But the implants were Nobel Biocare. But the Biomed 3i, the good thing for it, especially in this case, is that it can utilize the use of the CAM superstructure that fits on the other implant system. Okay, this is the example of the final CAM structure that fits on the full arch implants. Okay, and this is an example of a full contour diagnostic or definitive, or the final wax up that I have carried out in the lab with support from my technicians in Eastman. So this is the final wax up. Okay, this is an example of how you can actually fabricate a customized abutments for a cement retain restoration. So you do a bit of a milling to make sure your bridge work will actually be placed in a parallel as possible, and then you do some kind of a polishing as well, and then you do some full contour wax up, and then before you do the porcelain work. Okay, so this is an example of a cutback. I think if you remember when you did all your prosthodontics technical work. When doing the undergraduate, you do a full contour crowns build up or wax up, and then you cut back, and then you invest and cast, and then do the porcelain work. So the same goes to, there's no difference. I mean, whether it's implant within bridge work, implant within crowns, or crown and bridge work, the concept is the same. Okay. Okay, now we go through the case selections. So I have some of the case selections that I want to present. There are single tooth implant placement, partial replacement case, overdenture using implant abutments, and full arch. I just have to admit that I am very fortunate being a postodontist who have been, I would say, surgically trained and restoratively trained in implant delivery, because I think in Eastman, I think each division in Eastman, all surgeon, all maxillofacial surgeon, periodontics, postodontics, they are all doing the placement and the restoration of the implant. There's no such thing as implants being in any, basically, or any specialty that we have actually gone through with Dr. Firdaus. Even nowadays, actually, the ENT surgeon and the plastic surgeons want to do the implants. So it has been so widespread. It has, the skills has been there. A lot of people are learning to do the implants and restore with the implants. Okay, but what we want to address is actually a proper, adequate treatment planning. Okay, so this is for example, a single tooth implants. I have actually shown the photo earlier. So the healing abutment is healing well. However, the margin of the upper left one is not so much matching with the right side. So this is when we start doing the provisional work in order to get soft tissue profile. So we take an impression, pick up impression technique, and we use a temporary coping abutment, and then we build up with acrylic bond to composite. So that is an example of a screw retained provisional crown, single tooth, and we actually fit into the patient's mouth, and that is a provisional crown. There is a blanching on the upper left one, as you can see here, and it will take some time for healing. So we want to give some time to allow it for maturation of the soft tissue before we move on to the final work. Okay, moving on to partial replacement case. This is an example of two ankylosed implants with a custom abutments. So we mill them and we make a provisional bridge, and then we put in the patient's mouth before doing the final work. Okay. This is an example of slightly more complex cases. The patient has had a generalized chronic periodontitis. However, he has gone through maintenance phase. However, has a bit of a relapse. So that's why you can see some plaque and calculus build up. But then we re-establish, we do a bit of a cleaning and things like that, get the oral hygiene back into the track. And then we provide the upper acrylic partial dentures. We put 4 implants for a 6-unit bridge work. That is a PICC abutment. This is a PICC abutment, which is to allow soft tissue profile around that area. And then this is an example of the implants, as you can see, and 2 angulated abutments as well on the upper right 3 and upper left 8. Okay, then we do the final impression pickup, and then do a more major laboratory work that I myself haven't seen before, which we use. We start making the superstructure starting from the wax up, and then do the duole and the metal work, and then do the porcelain with the pink gum. So this is what we call the power of pink gum. The patient has a very low smile line, so the pink gum does not show, the abutment does not show. The patient is very happy with the work. But this is the type of cases that the patient want to go through without resorting to the complex bone grafting procedure. So this is an example. So this is the final work and the patient's smile line. So the patient is very happy. And in restoring the case in a conformative occlusal approach, the patient also have a lower partial cover coat to replace some of the missing teeth. Okay, right. So hypodontia cases. So we did a timing extractions, and then we put the implants in. So for the upper, it's difficult because we cannot achieve the screw retain, so we resort for cement retain restorations. And then those are the example on the lower left photograph with the PICC healing abutments. And this is before, and then you can see the after. As you can see, hypodontia cases is not so straightforward. You can see some of the lost gingival tissue on the upper right 3. However, we try to we make the crown slightly long as well. Luckily, I have not been asked this in the MRD exam, also the membership exam, so they don't ask this. So, you know, it's okay. Okay, so you can see some of the porcelain work on the masterclass. You can see some of the metal works as well. We're trying the metal work before we do the porcelain build up. So these are the cases that you can embark on for complex cases where the patient will pay a lot of money. So you may want to do things right. So this is an example of a customized soft tissue impression using pattern resin. When you have used your provisional to develop the soft tissue, take an impression and then deliver for the final work. This is a slightly more simple cases involving overdenture on locator abutments. So this is a nearly 80-year-old patient, 70-plus-year-old patient who is still fit and then wanting to have all possible treatments in her mouth. And she has upper partial comb denture and a lower complete overdenture on 2 locator implant abutments. So it's a normal size implants, but we use locator abutment to have what we call the female components that will attach or clip on male parts of the implant, which is locator abutments. Okay, an example of full arch I have actually shown you earlier. The implants with Nobel Biocare and then the healing, abutments, and then we restore with the CAD-CAM wrapped around titanium superstructure with acrylic bridgework. Okay, so you can also consider a lot of different types of metal superstructure. You can consider either non-precious, semi-precious, highly precious, titanium, gold, bar, and then with either acrylic, gold, porcelain work and things like that. So it's all depending on how you want to go about in terms of managing the case. Okay, so this is an example of conventional clip on overdenture on a gold bar. But I think nowadays we now move on to use locator abutments or maybe provide fixed implant prosthesis rather than removable. Okay. Something that I have to talk before I close my lecture is about maintenance phase. It's so important that we, after rehabilitating the patient's occlusion or replacement of the missing teeth with implants, we have to teach the patient on how to clean the implants, especially on more complex bridge work using the superfloss. You have to get through in superfloss and tidy up so that there won't be any chance for perimucositis or periimplantitis or any inflammation around the gum. So it's something that you have to go through and not forget to do that. So in some way, implant rehabilitation is highly driven by the restorative needs of our patients who usually want to have better aesthetics. And implant dentistry is a challenging profession which requires some kind of skills as well and knowledge in any of the disciplines. And multidisciplinary teamwork is highly encouraged. Okay, so here you go. So I think I'd like to welcome to